Welcome to week 5, everybody. You are halfway through. Doesn't that make you happy? Sort of. Right. Okay. We're going to jump right in to finish up with last week's chapters 13 and 14. And then we're going to jump right into chapter 17 and 18. So I want everybody to just take a deep breath and remember that the radiology chapters, chapter 15 and 16, are, hold on a second, let me get out of this. Ugh. Okay. Can I get out of this? Yes, I can. Okay. The chapters 15 and 16 are not going to be covered until week 7. So don't do anything with them yet. A couple people have tried to take the exams and got all screwed up because it's the radiology stuff. So skip over 15 and 16 for now and go to chapter 17 once you finish with 14. So we're learning to count in a completely different way. We go 1, 2, 14, 17. Yeah, I know, it doesn't make any sense, but it's for learning. It's so much better for us to concentrate on the radiology once we've got everything else under our belt. So I am going to put the presentation up. Feel free to jump in anytime you need to. And if you can't see it or anything like that, just give me a yell. There. It's nice when things work. Okay. All right, so this is the end of the lesson from last week. It's chapters 13 and 14. And it deals with medical emergencies and pain and anxiety control. The most important, both of these are really important topics, but of course the pain and anxiety control is sort of an everyday thing. And the medical emergency is a really very rare thing that happens, but one that we need to be prepared for. So some learning objectives around the medical emergencies. And you can read and go through these, but the main thing that I want you to remember about medical emergencies is that we are supportive as dental assistants, which means that it's our job to make sure that the doctor has the medications they need, not to administer them, and also to make sure that we know our role during an emergency and that we alert the EMS, which basically is 911. So those are the big things. And then some things that we do to support medical emergencies all the time are making sure that the drug kits that we have in the dental offices are up to date, that things aren't expired, and that we know where everything is. So we are going to look at a couple of different scenarios tonight with medical emergencies. And you're going to feel a little bit overwhelmed as we go through these, but I want you to remember that you are looking basically to be supportive and not to diagnose. All right, so what's an emergency? Something that requires our immediate attention. And being prepared, having our equipment ready are the main things that we need to be able to do as dental assistants. So for preventing an emergency, the easiest way, hold on a second, I want to get rid of, that's a little irritating. Sorry, guys. You're not frozen. It's me. There we go. Okay. So the easiest way is to make sure that we have a thorough health history for each patient. And to talk about the health history with the patient, especially if the patient is an older patient or if the patient does not speak English as their first language. Because sometimes those patients will miss things on the health history. And so having a conversation around that also builds rapport with the patient. So you communicate, you make a friend, and you also may uncover something that didn't get put on the form. Prescription medications the patient is taking are basically the main thing we want to know about. We talked a little bit about vital signs last week, and those things can give us a baseline on how a patient usually is. But we also want to know, what has happened to them in the last year to 6 months, major surgeries, heart problems, things like that. Of course, allergies and anything that is chronically wrong with a patient is also something that we want to pay attention to. So the problem with an emergency, of course, is that you don't have time to look up what to do. And that is true of almost everything we do in dentistry, is that having a book doesn't help you very much because you don't have time to consult it. So it's always important to update and review a history beforehand. So our role as dental assistants when we seat the patient is to say any changes in your history since the last time you were here, and then to just verbally review the medications that are on the chart and say, are you still taking this? So those things, starting that conversation, and then communicate with the dentist if there are changes. The dentist will often come in and then ask the same exact questions that you just did. And don't be offended. It's part of what they need to do to make sure that they've got their legal bases covered, as well as to make sure that the patient is well treated. A lot of times, as I've mentioned before, your patients will not speak to you about something, the dental assistant, but they'll tell the dentist everything. And you'll be like, what did I do? You didn't do anything. It's just the way patients respond. So we remember that being CPR certified, being able to do the Heimlich maneuver, which is what we do when patients may be choking, is a standard of care. So being able to do these things is what patients should expect no matter which office they come to. So those are things. So this is a good time for us to talk about CPR and the fact that you have paid for CPR included in your tuition. But the fun thing about it at this point is what we need to do is locate a center that's close to us that offers CPR, basic life support for healthcare providers. And I can help you with some of these. What I'll do is I will look up where those places are close to the adult ed centers, and then that may help you to find a place. So usually hospitals will offer this.
Kelly?
Yep.
What if we are already certified?
If you're basic life support certified for healthcare provider, if you're BLS for healthcare provider, you're all set. If you don't have, so if you're just CPR certified and not BLS for healthcare providers, you've got to take it again. So,
Okay.
But it's good because it's always, what is your situation? Do you have?
I think I just have the regular CPR first aid.
Yeah. So you're probably going to have to redo it.
Okay.
The good thing is that it's every 2 years, so even if yours is recent, you'll get an extra extension on, the last time you took it. Yep.
Thank you.
So, no problem. So once you take that, then you send the receipt to the school, and they will reimburse you. So that sometimes is a barrier to being able to get this done. And if it is, I want you to communicate with me and with the school, and we'll see what we can figure out. Because I am also a CPR instructor, so I've been trying to figure out how on earth to do that with everybody from all over this state. All right. So signs and symptoms are something that we should always be observing in our patients. So signs are what we see. So I might think the patient, they look pale, or they're sweating, or they look red. And a symptom is what the patient reports. So a sign is what I see, and a symptom is what they feel. And oxygen is the most commonly used drug whenever a patient is reporting a symptom or we are observing a sign. So one of the first things that we should be able to do in a medical emergency that happens in the dental office is to be able to get the oxygen and bring it chairside. You may or may not attach it, but at least you've got it chairside so that the dentist can then attach it. Some other things that are used during medical emergencies, are listed here, and we will probably touch on each one of them, as we go through. So where are all these things stored? Usually in a kit. And Our main thing is to maintain the kit to be sure that the expiration date is current and that the oxygen tanks are checked weekly to be sure that they work. So a kit looks something like this. Luckily, they know that this is not something we do every day, so they color code it, which is pretty cool. So what's your responsibility again? To recognize the signs and symptoms, communicate with the dentist, and then assist with whatever they need, whatever the dentist needs. So the following slides are what we commonly see for medical emergencies. And I will go through just a couple of them. The first one I'm going to go through is fainting because it is so common. So fainting is some of what we see and what the patient feels. So the patient may feel flushed, which means that we would see redness. The patient may feel nauseous, and they tell us so. What we can observe as a sign is a rapid heart rate. So if a patient is hooked up to a monitor, you'll be able to hear that rapid heart rate. Low blood pressure, which is also called hypotension. We can see the patient sweating, and pallor, which means paleness. So all these things are signs and symptoms that the patient might feel of an impending vasovagal syncope. So the fancy name for fainting is syncope. And we call it vasovagal because it is usually easily reversed by putting the patient into Trendelenburg, which is a word we learned last week. Trendelenburg is a subsupine where the head is lower than the heart. So the blood rushes back to the brain, and then the patient typically wakes up. So fainting, they go unconscious for a moment. We put the chair down, they wake up. My story with vasovagal syncope had a big guy in my chair for extractions. He had tattoos all over him. And when I gave him the anesthesia, out he went. So I gave him an injection, and he lost it. Now, you would think a guy full of tattoos would be able to take a needle, but in the mouth, things are different than they are on the skin. And so we put him immediately into Trendelenburg, and he woke right up. So that's the only time I've ever had a patient faint on me. And he was probably just really anxious about the extractions that he was going to have. He was having some teeth out. So these are things that can happen, and when they are managed, in the way that they're supposed to be, treatment can resume in a case like this if the patient feels okay to go ahead. And sometimes the emergency is more serious and treatment can't resume. So there's hyperventilation. Just a note here, breathing into cupped hands is better than breathing into a paper bag. So the patient's cupped hands are better than a paper bag because I think a lot of us were often taught if someone's hyperventilating, give them a paper bag to breathe into. But the hands are actually better, and you don't have to run and get anything. So hyperventilation is one we see because patients are nervous, anxiety. So fear and anxiety. Asthma attacks triggered by fear, triggered by anxiety. Usually the patient will use their own inhaler in this situation. And this is just a very quick view through this. So your job is going to more be aware of the patient and then let the doctor do the diagnosing and the administration of medications, which is why I don't spend a ton of time on this. So there's diabetes, hypo and hyperglycemia, have different symptoms, both of which result in a 911 call. So really, we may or may not need to administer different medications, sugar or insulin, depending on what is causing it. But mostly we know that we're going to need some help from the emergency system. Chest pains, 911 all the time, no matter what. Even if the patient has them commonly, which is called angina, or not. And then stroke, 911. Allergy, 911. So most of these are managed by supportive techniques until the ambulance arrives. Okay, so chapter 14, the pain and anxiety control, is where we will go from here. And what are we talking about when we're talking about pain and anxiety control? Well, most commonly we are talking about what the patient calls Novocaine, or local anesthetic. So that's what we're going to spend most of our time on, because that's what general offices do. Some general and some specialty offices will get further into pain and anxiety control using conscious sedation, which is usually a more specialized way of assisting. Okay, so fear keeps many patients from dental treatment even today. So for those of you who are younger and maybe haven't had a lot of dental work done, you might love going to the dentist, but you're going to meet a lot of people who don't. And so we never want to belittle a patient who is expressing such feelings. So telling a patient that they're being a big baby is a bad thing, right? So don't do that. So what do you want to do? You want to tell them that you know that this is difficult and that everybody has some degree of fear, especially when they have to let go of control. So it's about being able to trust the dental assistant and the dentist. And so we'd like to sort of build that trust. And you can see my cartoon there. I see my dentist regularly. I see him at the post office, the grocery store, but not in the office, right? So some things that we use to relax the patient can be chemical, like drugs. They can be physiological, like wearing headphones during treatment or having TV up on the ceiling, so distraction techniques. Also meditation in some offices. Psychological, so patient management, being able to talk your patient through something. All of these things can be approaches to treat pain and anxiety. So we're going to cover local anesthetics, nitrous oxide and oxygen to some degree, not very deeply, pre-medication a little bit, and IV sedation or intravenous sedation a little bit. So in a general office, if you've ever had anything done, you know that the first thing they do is come at you with this wonderful, tasty topical anesthetic. And the theory is, or the goal is, to sort of pre-numb the injection site. And it's a temporary effect. We use ointments, liquid sprays, sometimes patches. The biggest thing about topical anesthetics is that they have to be left in place for almost up to 5 minutes for them to work. So if you've ever had some topical placed and said it doesn't do anything, I don't even know why they bother. Usually it's because it's been taken out too soon. So we want to dry the mucosa, which means we'll take a little 2x2 and dry the inside where we're going to place the cotton-tipped applicator with the numbing gel on it, because that's usually the most common way you'll see this in the offices. So for maxillary teeth, in general, we're going right above the tooth. So we remind ourselves of the nerve supply and the anatomy. I know I said a bad word. Nobody wants to think about anatomy anymore. But the maxillary teeth, we're going to place that right above the tooth. And for the mandibular teeth, typically we're going from the opposite premolar. So if I'm working on the left side, I'm going to put this stick over the premolars on the right side, and it will end up on the cheek in the back, inside the mouth. So to remind us of the anatomy there. So the most frequently used way to control pain in the dental office is local anesthetic. And the patient might call this Novocaine, which it technically is not. They might call it a shot. They might say get numb. So a patient comes in and they say, am I getting a shot today? Do I have to get numb today? And our job is to kind of lessen the anxiety around that and say, yes, we may need to give you some local anesthetic, because that doesn't sound like anything, right? A shot makes people get scared, and local anesthetic using those words doesn't typically trigger the same reactions psychologically. So what does it do? It keeps the nerve from firing. And we call it local because it's in one place near the nerve, specific to the teeth that are being treated. There's some different terms that are used with local anesthetic. We've got induction, which is time from injection to numbness. We've got duration, which is time from injection until numbness wears off. And vasoconstrictors are often added to our local anesthetics. And what they do is slow down the intake and increase the duration of anesthesia. They also conveniently decrease bleeding. So they're very useful when a patient is having dental surgery performed because the bleeding decreases in the area that we need it to. The problem is they are not indicated for patients with high blood pressure, heart and kidney, liver disease, or pregnant patients. Most of the time we can use them in, small amounts in some of those patients. But typically, we won't be putting it out for those patients. So we have to pay attention as dental assistants to what kind of anesthetic we're putting out. Okay, so injection types. Infiltration is for the maxillary teeth. A nerve block is for the mandibular teeth. And the needle is color-coded in most offices. So the maxillary needle is blue. The mandibular needle is yellow. The maxillary is shorter. The mandibular is longer. And so we say the sky is blue, the sand is yellow. So why does that work? Because the sky, the upper, so what's up is maxillary, and that is usually the blue needle, and then the lower is the yellow. So it's a good way to remember it when you're getting your equipment ready for a procedure. So if doc says we're working on tooth number 3, we know that is a maxillary tooth, and we're going to need a blue needle for that, typically. Transfer, you can transfer the needle behind the patient's head or under their chin out of their sight. But you should never transfer a dirty needle back and forth. So once it's been in the patient, the doc should be the one to recap it. You should not be moving those back and forth because we don't want a needle stick. So this picture depicts the nerve in yellow like branches of a tree. So the infiltration injection gets those branches right at the very end, so kind of like the limbs that are way far out. Periodontal ligament, we can actually inject right around the tooth. This is typically only done for extraction or for scaling. It's not a very comfortable injection, hurts. A lot of pressure there. And then the block injection, so this is the mandibular injection, is right in the back of the mouth. And if we remember our anatomy, the nerve only comes out of the bone in one place in the back there before it goes into its bony tunnel. So getting this injection successfully is sometimes difficult. And it is important that we are able to understand what the symptoms we're looking for in our patient so that we can report them back correctly to the doctor. So this is a schematic, a diagram of how to put this thing together. And everything is color-coded. So you are going to load the cartridge, engage the harpoon into the plunger, and then thread the end of the needle through the diaphragm. So if you follow the colors, you're going to have to study this slide for sure. You can kind of get a sense of how this goes together. And next week I'll also have one with me, and I'll show you how to put it together on camera. So some other pain anxiety methods, we talked about some of the ways that are not medication up top, headphones, TVs. And then one thing that we often do is some oral or inhaled agents. So Valium, Seconal, Librium, these are good things that can sometimes be given about an hour ahead of time. And all of those patients will need an escort. They need somebody with them. Noctec or chloral hydrate is the best for children. And then we can also give Tylenol, aspirin, Advil, and maybe something stronger for pre- or post-operative pain management. Typically, though, I don't think you can be alive without knowing that we have an opiate issue in this country. And so the regulations around Percocet, Vicodin, Demerol, Dilaudid have all gotten much tighter. So usually those are not used unless absolutely necessary, and then in very small quantities. So we never prescribe as dental assistants. We don't ever give drug advice, even if we think we know. All right. So what do you do when asked a question about a prescription or a drug? You say, let me ask the dentist. So it's fine to put a patient on hold. And this is the one place where you want to be, I don't know, let's ask the dentist, even if you do know. So sometimes it's difficult to not give advice when you're aware of it, but it's important not to. And then always record whatever was asked and answered in the patient's chart, along with whatever was prescribed or given in the patient's chart. So nitrous oxide is the next thing we look at. Nitrous oxide is a mix of nitrous oxide and oxygen. This is otherwise known as laughing gas. All right. So, and you tell your patient that they're going to feel warm and floaty. The patient is still awake. They don't go to sleep. They are still in control. It is not for pain. It is only for anxiety. So once a patient has nitrous oxide, oxygen, analgesia hooked up, they still are going to need the injection. So what does this do then? It helps them feel better about the injection, which is why it's wonderful for kids. So 50% is the max allowable on the nitrous, and we always end with oxygen. Before we start with oxygen and we end with oxygen, so 100% oxygen. So the patient is back to their normal self in 5 minutes. That's the other beauty of laughing gas, is that it does not stick around. So a chatty patient, a patient who laughs a lot, is not a good thing, because then they're blowing nitrous oxide into the air, and it's bad for the dental team. We always need to have a scavenger system to pick up that excess nitrous oxide that goes into the air as the patient is breathing, so that we don't end up with the effects of nitrous. I can't imagine being on laughing gas and actually performing dentistry. That would probably be bad. Yeah. So one of the things too about nitrous oxide is fairly safe for almost all patients, but there are a few patients who it's not safe for. And I think I do have that. Nope, doesn't. Pregnant patients are the biggest patient it is not safe for. So nitrous oxide has been shown to cause spontaneous abortion and miscarriage, basically. So it's bad. And so as chicks, if you're a chick and you're thinking about becoming pregnant and you work in an area where nitrous oxide is administered, that is also a consideration for your own health as well. So things to just pay attention to. I used to work with someone who spent years trying to get pregnant. She was the lead assistant. As soon as they took the nitrous out of the office, yep. So caution always needs to be taken when we're preparing and assisting in the administration of a drug. All right. Any questions about any of this? Sounds pretty quiet out there. All right. So take the exams for chapter 13 and 14. And for your learning pleasure, I have put 2 reviews on here. Wink, wink, nudge, nudge. All right. So I know that this is a lot of stuff, and it's a lot of stuff in a short period of time. So there are some really important points that I've pulled out here that you might want to look at. All right. Great. I know you're all laughing even though you're on mute, right? Okay, good. All right. So we are now officially in week 5 with these chapters here. So we're at the halfway mark, and we're starting with chapters 17 and 18. And so where are we headed? So tonight we are headed for prevention, instruments, burrs, handpieces, cements, and restorative materials. Nothing big. So there's a lot of material in these chapters. The one thing that you can kind of hang on to is that most of this information you need a very basic understanding of, because you are going to learn it while doing. This is the stuff that you want to have a mastery of in book, but realize that most of your learning about these things is going to come by holding the materials and the instruments. So our objectives are in Chapter 17, focus on periodontal disease, toothbrushing, and decay, and preventive care. So, all right. So what is preventive dentistry? It's a partnership, and it is a partnership designed to give the best lifelong oral health to our patients. And there are a lot of different things that go with this partnership to make the best lifelong oral health. And we're going to look at each one of these things. So patient education, nutrition, plaque control, fluoride therapy, and sealants. That is what encompasses a preventive dentistry program. So what goes into the body, your patient's understanding of how that affects their health, your patient's understanding of and their skills that they have at removing plaque, also the things that we can do in the office and what the patient can do at home to fight decay and disease, and then some preventive measures that we do in the office like sealants that keep disease away. So let's talk about plaque. Plaque is a soft, sticky, colorless deposit that sticks to your teeth. And so what I want to say right now is that if you've seen plaque, you actually aren't looking at plaque. So when you see someone who maybe hasn't brushed their teeth in a while, and you can actually see the food debris on their teeth, it has plaque in it, but plaque is colorless. So plaque is not something that's visible, typically. And what is plaque made up of? Plaque is bacteria and some sticky stuff called pellicle. Pellicle are proteins in the saliva. So pellicle forms about 20 minutes after we brush. So we've got proteins from the saliva that begin to stick to the tooth. That's not harmful. What's harmful is that the bacteria then stick to those proteins, and then they start to multiply, because that's what bacteria do best, is they make more of themselves. So the plaque that harbors the bacteria that cause caries and periodontal disease are the most detrimental, or the worst for our mouth. So the two bacterias, and we met these a few weeks ago, Strep mutans and Lactobacilli, are the two bacteria that cause decay. And there are about 200 to 500 million of these bacteria per milligram of plaque. Milligram is like the size of your fingernail, like the width of your fingernail. So you can remove plaque by brushing and flossing, but you can't remove it by rinsing, swishing, or running your tongue over it. So that's something to grasp right away, is that plaque needs mechanical removal. The next deposit that we see on the tooth is called calculus, and it is not math. That's a good thing, right? It's a hard white yellow deposit. Typically it's called tartar. And the minerals from saliva and plaque come together to make this a hard deposit. It causes a rough surface that attracts then even more plaque. The patient cannot remove this. You need a dentist or a hygienist to remove this. And when I say they cannot remove, what I mean is they can't remove it safely. So I know people, I know construction workers who have taken nails and popped the tartar off of their teeth. The problem with that is it hurts the tooth and the gum. So both plaque and calculus can be located above the gum line or below the gum line. So we return all the way to week 1 and our terminology, and we say supragingival or subgingival. So here we have a 10-day-old supragingival plaque, and then some supragingival calculus over on the right. So both of these are above the gum, the two different types of deposits that we see. So caries is the most common disease of childhood, and it is also one of the most common dental diseases. This is why we see most of our patients. Caries is another way of saying cavity. And how does this all work? Well, sugar plus the bacteria that's in plaque forms acid. Acid plus a healthy tooth is what causes decay. So when someone says sugar causes decay, that's true, but it needs bacteria from plaque in order to make it happen. So basically, your bacteria are taking in sugar and pooping out acid and causing holes in our teeth. Lovely equation, right? So here are some pictures, more pictures of dental decay. Because decay starts small, as we see up here. Let me just put my pointer on. So as we see up here in this picture, this is called incipient caries, which means it's just starting. It's just a white spot. So white spots can often be the beginning of a cavity. Doesn't mean they always are. So if you have a white spot, don't freak out. Get an opinion from a dentist. The frank cavitation is the next stage, or the hole. And then if frank cavitation is not checked, we get rampant decay, which means it's everywhere. So here are some different ones. And if we're thinking about cavity classes that we started to learn last week, these are class 5 because they're gum line cavities. These here are class 1 because they're pit and fissure cavities. They're in those pits, those grooves. And if we look at this one here, this is a class probably 4. So 3 and 4 here in the front because it's involving the front teeth and the edges. Here's some more pictures of root decay, root caries. This, remember, is caused often by medication or drugs, legal or illegal, because they dry your mouth out, and a high sugar diet at the same time. So often something like this on the right may be due to a patient taking a medication that's drying their mouth out and them not realizing that that's part of what's going on there. There's some more class 5 decay. I have seen decay like this caused by patients holding cough drops in their cheek that are filled with sugar for a really long time. So if you have a habit like that and then add a dry mouth to it, say the patient is a smoker, that is going to, cause something like this to happen. And then, of course, listen to me, of course, meth mouth is part of this syndrome as well. And meth and other drugs will cause this type of gum line decay. All right. So the next most common disease is periodontal disease. And there are 2 types of periodontal disease. There is gingivitis, and then there is periodontitis. So both of them have that itis on the end of them, which means inflammation. So inflammation of the gingiva is reversible, which means that with a cleaning and some good brushing and flossing techniques, the patient does not need to have this disease. They can reverse it. Periodontitis, which is inflammation of the periodont. Does anybody remember their terminology there? Inflammation of the around the tooth area, is the progression of gingivitis. So when gingivitis isn't treated, it can turn into periodontitis, which is not reversible and causes loss of gum, loss of bone, and eventually loss of tooth. And one of the ways that we assess our patients to find out how healthy their gums are using the periodontal probe, which is an instrument that we met a couple weeks ago. So the periodontal probe is used to measure the sulcus, and the sulcus is how deep is the space between the gum and the tooth. Now, it should only be about 3 millimeters deep, but if it is deeper than that, that's when we end up with the trend towards periodontal disease. And you can see from this picture that there are different types of probes that are used to measure this. This is not a painful process. And if you see this probe over here, this one's my favorite because it has green and red. So if you're in the green, you're okay. All right. So this is what periodontitis looks like, and this is what gingivitis looks like. So you can see that there's just this redness right along the margins of the gingiva, right along the edges of the teeth. And this can be reversed if we clean it well and the patient changes their habits. But over here, not reversible. So we still want to clean this up because we don't want it to get worse. But the patient will not be able to get back their gum and bone that they've already lost on their own. So they're already at a disadvantage there once they move to periodontitis. So you're going to get a lot of questions about toothbrushing when you are in the dental office, and these are things that we can answer and be a part of the patient's best oral health by having conversations with our patients around brushing. So the patient often says, how often should I brush? How often should I floss? And the answer typically is based on removing all of the plaque biofilm rather than the number of brushings. So at least 2 brushings and flossings are recommended each day. So I'll tell my patients at least after breakfast and before bed. But I often say to them, but if you can do it after every meal, you're doing yourself a great service. And some people have the means to do that because they have jobs that will allow them to, and others, don't. So for many years, I worked for the Teamsters and their truck drivers, and they had no chances to clean their teeth, very few. So you can imagine what we saw. Lots of teeth, a lot of periodontitis. So the longer the bacteria remain undisturbed, the more damaging that plaque biofilm becomes. So we want our patients to disrupt it at least once a day, and twice a day is recommended. So at least for 2 minutes, don't forget to brush your tongue. You can wear away your tooth surface, especially right at the gum line. And so you want to always have a soft brush or an extra soft brush. Why do they make medium and hard brushes? I don't know, but don't buy them. They're very bad for your teeth. So stick with the soft, stick with the extra soft if you can find them. They're harder to find, but they are out there. Brushing should feel like a massage. It should not feel like you're cleaning the tiles of your bathroom. All right. So your brush should air dry. You want to replace it every couple months. And the Bass method is the method that is taught most often. And then a disclosing agent can be used on a patient to make the plaque visible. And I believe I have pictures. So here is a patient with a disclosing agent. So you may have had to chew one of these tablets when you were in the dental chair, or taken a swish of something that colored your teeth, so that you can see where you're missing, right? So this is a great tool to tell a patient, this is what you're not brushing when you brush your teeth. When I look at a patient like this, I think, what are they brushing then? I don't know. No, but it's our job to help them get better at it so that they don't end up with unchecked dental disease. So here's the Bass method. Bass method takes the toothbrush at a 45-degree angle, and it engages the gum with the bristles, and we just do a little vibration back and forth. And you can cover about 2 teeth at a time with a normal toothbrush. So if you start in the back and you do a little vibrate, and you may add a rolling stroke to brush the plaque away. So you're vibrating and rolling all the way around. It should take you about 2 minutes to get through the whole mouth. Notice that down here in the lower anterior, so down here in the front on the mandible, the brush is held vertically. It's straight up and down there. So some different ways of brushing than, most of us as kids were taught to go circles because that's what works for kids. And then when we reach adulthood, nobody bothers to correct us and say, okay, now that you're an adult, you got to do a little more, right? So this is one thing that we can teach our patients and ourselves. There's a great video with your textbook, I believe, that you can watch for this too. So what's better? Is it better? Oh, sorry. Trigger finger. Is it better to have a regular toothbrush or an automatic? And the answer is there's no difference as long as you use them correctly. So some patients do better with an automatic toothbrush, and for them, that's what's best. But some patients do fine with a manual, meaning they do fine with a regular toothbrush. So that's what's best for them. So there are offices that will sort of encourage the use or the purchase of the automatic toothbrushes because they sell them in the office. And I think that's fine as long as the patient could stand an upgrade, which means they're not doing well with the manual brush. Then it's worth it to try it. But if you're doing a good job with a regular toothbrush, then $3 is all you need to spend. So the thing is, just like all of us, if we have something to do it for us, we might be more likely to do it. So that's why the automatic can be better. This is what it looks like if you brush too hard. So you can actually wear away your tooth structure. Now, there's no cavity here at the gum line, at those arrows. There's no decay. But there might as well be in terms of what you've lost from the tissue. So you want to be really careful about staying in one place. And one of the things, if you're a person who does this or you know somebody who does this, I tell patients if they're right-handed, switch to your left hand because you don't get as much pressure with your left hand as you do with your right. So that's one way to help yourself not brush as hard. And my mantra, the thing I tell everyone I know, only floss the ones you want to keep. So if you don't want to keep them, don't floss them. You may have seen that there was a report earlier this year that flossing is not necessary. So you don't have to do it. That may or may not be true depending on who you are, but I will swear up and down the only reason I still have mine is because I floss like a mad woman. So I'm a serial flosser. I have a problem. I floss when I drive. I floss all the time. So that's bad, flossing while driving. Don't try this at home. But you should do it before you brush because what happens is if you wait till after you brush, your teeth feel clean and you forget. But if you do it beforehand, you're getting out all the gunk. There are patients who have larger spaces and they may need something bigger. And that's when all of these fun things come in. So if you never knew what this little thing on the end of your toothbrush was for, that is for stimulating the gums and also being able to push out if the patient has a large space and has some food in between them. So they can use that to get in between the teeth. And that's really what all of these do. These are called interproximal or proxa brushes. This is a Stimudent that uses, it's a toothpick-like thing. I'm not a big fan of toothpicks unless they are rounded on the ends. Most people who use toothpicks use them because they're pointed, but the points can actually damage the tissue. So you can actually like poke holes in your gums with these and then lose tissue. Another thing that we sometimes need to educate our patients about are floss threaders. They go underneath fake teeth that are cemented in, so like a bridge that a patient can't take in and out, but they still need to clean underneath it. It's kind of like a needle and thread. So it's not a needle, but it's a stiff plastic thing that will allow you to go under. If you had braces, you know what I'm talking about. Because you can't floss when you have braces. But you can floss, but not regularly. It takes a lot more effort. And then for some patients, the water pick flosser is one of the best things that they can do because they just won't floss any other way. Just as an aside on that, I have seen patients who don't brush almost at all. That they come in every 6 months for their cleanings, but they don't brush. So people are out there, believe it or not, that don't brush their teeth. All of that makes me crazy. I have to put a piece of gum in my mouth. Sorry. Okay. I'm one of the dentists that recommends Trident. Okay. Fluoride is a mineral. Fluoride is used to strengthen the enamel to resist the acid that causes the cavity. So we remember that sugar plus bacteria equals acid, and acid plus tooth equals cavity. But tooth plus fluoride equals harder surface that is resistant to the acid. So fluoride is a great strengthener. It is ingested in water and in beverages and in food. And so we call that systemic fluoride, which means that it gets right into our saliva. Topical fluoride is applied only to the tooth surface. And of course, our biggest source of that is toothpaste. But in the office, we often paint it on twice a year, especially in younger patients, for protection. And
Kelly?
here, yes.
I just had a question. I read
Yeah, go for
somewhere
it.
that green tea had natural fluoride in it.
Mm-hmm. Yep.
Yeah,
It's
okay.
a great thing. Yeah. Green tea has natural fluoride in it, and it's also I've seen a lot of good things with it. The only thing I would say is watch the stain.
Yeah.
It does stain your teeth. Yep. Yeah. That's a good little plug for green tea.
We have a question.
Go for it.
Do you have to have fluoride when you're an adult, or is it just when you're a kid?
You don't have to have it when you're an adult. It's best to take it in while your teeth are still forming. So that's till about you're 14. As an adult, you may run into a condition where you need fluoride to keep your mouth healthy. So for instance, patients who may be having cancer treatment, their mouth gets really dry and they are very susceptible to cavities. So what we like to do is give them a fluoride treatment that they can use to fight off, the process that's happening that they can't control. So adults do sometimes have it, but they don't need it, usually.
Okay.
Sound good?
Sound good.
All right. Okay. So there's a fluoride tray here. This is a setup for the foam type of fluoride. This is not used very much anymore because we have varnish, which is like a paintbrush. Fluoride is toxic in high concentration. Overexposure before the age of 6, so children who are younger than 6 who are overexposed to fluoride end up with stains on their teeth that is called fluorosis. Some sources of fluoride are in the water supply, in the food that we eat, in processed meats, processed chicken most commonly, in mouth rinses and toothpastes. Well water may or may not have fluoride in it, so a young person may need to be prescribed it, as well as get it twice a year because they're not getting it in their water. So it all depends. Bottled waters are not always reliable in how much fluoride they have or don't have. If you have a well, you should have it tested to see if you have fluoride or you don't. If you're in a town and you have town water or city water, they often treat it with fluoride, so it's already part of your life.
I have a quick.
Yes, absolutely. Question here.
Can iron in your water stain?
Yes,
as well?
iron can cause good stains on the teeth. Yep, nice brown stains. Yep. Yeah, lots of things can. Chlorine can too. So if you're like a big swimmer, if you swim often, we see like a stain, a green stain on the teeth from chlorine. So yeah, my hair turns green too. That's another story. All right. So for some reason I don't have pictures of fluorosis here, and I thought I did, but it's fluorosis. There's a lot of discussion about fluoride and safety, and I did send out an article to someone back a few weeks ago. If you're interested in knowing more about fluoride, I will happily send the article to you. It's from the American Dental Association. Every question you can imagine about fluoride is in there. So it's a very long document. So let's chat about nutrition for a moment. So carbohydrates are the enemy, both to chunky people like me and to our teeth. So carbs are like the thing that just won't go away, right? So whether or not a carbohydrate is sweet, it will cause decay. So all carbohydrates have the basic building blocks of sugar in them, which is what those bacteria like to make their acid from. So fruit juices, fresh vegetables, and fresh fruits are the best, gosh, I can't talk. They're the best choices for your teeth because they stay on the teeth for less time, and their sugar is lower than other things. Obviously, the worst things are cookies, cakes, candies, and other sticky things that we eat. So one of the interesting things to think about, though, is crackers. So crackers, and I think we've talked about this before, crackers seem like a great choice if you're faced with looking at a cookie or a cracker, right? But crackers are actually stickier than cookies are when it comes to the teeth, or most cookies. It depends, of course. But you want to sort of just realize that the stickiness is the big deal. So things like dried fruits are much worse for us than fresh ones because they stick to the teeth. So vitamin C is a vitamin that used to cause, or will cause, if you don't get enough vitamin C, your gingival tissues, your periodontal tissues do not heal well. And so pirates used to get scurvy because they would be sailing for a long time without fresh fruit. And so they had no source of vitamin C in their diet. It is one that has to be taken in. It is water soluble, so it has to be taken in on a daily basis, and would be the result. So that's why pirates had bad teeth. Isn't that a lovely little fact? Now you know. All right. So there are plenty of different things that our nutrients do for us. Carbohydrates are for energy. Protein is for building and repair of body tissue. Fats are for temperature regulation in the body and cushioning of our organs. Water is life. That's not a meme. That's true. So water is life. Vitamins for growth and development. Vitamins B and C are water soluble and are easily destroyed by cooking, so we have to eat them daily. Vitamins A, D, E, and K are stored in fat in the body, and we do not have to eat them daily. And then we have minerals that are needed for proper function. There's a variety of minerals. Some of the more important ones for the oral cavity are calcium, phosphate, vitamin K, which is good for clotting. So there's a bunch of them. Okay. The main thing is to not lecture your patient when you're talking about prevention. Create awareness of problem and solution, and then help with the skill practice for developing. So if a patient says, oh, all I do is eat carbohydrates, oh, you shouldn't eat carbohydrates, that's not the way to do it. So what you say is, can you think of one carbohydrate that you could substitute for, say, a fresh fruit or, something that is healthier for your teeth? And that's the way to begin the conversation. Any questions? Okay. Chapter 18 talks about coronal polishing and dental sealants. And in Maine, you have to be an expanded function dental assistant to perform this, which means that this is a few years off for us. So you need your CDA, which is 2 years away at least, and an extra course to take it. So I'm not going to spend a ton of time here. I'm going to spend more time on what you need to know to assist it than I am on how to do it. All right, so there we go. All right, so what is coronal polishing? That is, and we've talked about this because we talked about our rubber cup and our Profi angle. So this is the end of the cleaning when they polish all of the stain away. Feels like you have a mouthful of sand. Then you rinse out and everybody's happy, right? Your teeth feel nice and clean. And this is done either by a hygienist or by an expanded function dental assistant or by a dentist. And most states require an extra certification for this. We will have to do coronal polishing before we place sealants, before we place a dental dam, sometimes before fluoride is placed, before orthobands are placed, which is braces, and then before cementing crowns and bridges. So basically what coronal polishing is cleaning off the crown of the tooth. so that we can do other things to it. So we typically don't want to do this for patients who have newly erupted teeth or sensitive teeth because it does take a layer of the tooth off, and the outside is the most healthy. We don't want to take that off if we don't have to. And so there are a couple different kinds of stains, and we're going to look at these. So stains on the teeth can either be extrinsic, meaning they're caused by food and drink and tobacco or other agents. So there's a couple other things that cause it. Or they're intrinsic, which means they come from inside the tooth and they cannot be removed by polishing. So the biggest thing is you want to know by looking most of the time which ones can be removed and which ones can't. So the ones that come from inside the tooth, you cannot polish away. Fluorosis is one of them, and so is tetracycline. So when tetracycline is taken by mom during pregnancy, the child's teeth come out stained, and that cannot be removed by polishing. What do you use for polishing? A hygiene handpiece or an air polisher. And then if you're using the handpiece, you want your Profi angle, your Profi cup or Profi brush, and your Profi paste down here. And I have a key for this, so if you go back over these presentations, you can kind of quiz yourself on what these things all are, right? And then some down there too. So Profi paste comes in different grits. So you can use a fine grit or a coarse grit. And here is how I would set it up for the dentist or the hygienist or myself if I were doing it. And notice these little tablets up here. These are the disclosing tablets. So it is often a good idea to have the patient disclose so you can actually see the plaque that you're going to remove, because remember, plaque is colorless. And I have a key for this slide as well. That's how you do it, is by overlapping the strokes there. So that's what it looks like in the mouth. And then the next thing we talk about in this chapter is sealants. Sealants are a plastic coating, basically, a resin material that is painted on the pits and fissures of the teeth to prevent decay. So the pits and fissures are so small that a toothbrush will not be able to get into them. So they're impossible to clean. And the only way to prevent a cavity in those pits and fissures is to seal them. And you may have had sealants. Sealants tend to last a few years and then they wash away. And so our biggest goal with sealants is to get through the cavity active period, which goes from like age sort of 13 to age 18 or 19. These are the times that people get the most cavities. So that's usually when sealants are applied by like age 14, and we want them to last until the patient's, in their early 20s if possible. So we're going to look at, they're almost 100% effective at preventing cavities. And because they're a physical barrier, they prevent the acid-producing bacteria from getting in there, down in the pits. So this is what it looks like, from the side. The sealant gets down into that pit and fissure on the enamel, and it keeps the bacteria and the carbohydrates out. Because otherwise, wouldn't this be a nice home for some bacteria and carbohydrates? Can't get to them. Nobody can brush me away. And this is what it looks like up close. You can see that the tooth has deeper pits and fissures than the toothbrush is able to get into. So microscopically, the brush is too big. So when do we place these? Newly erupted teeth within the last 4 years, when there are deep pits and fissures, and when a patient has a high decay level. If they already have a filling on the tooth, no sealant. The filling has to be done. Or a cavity on the tooth. And this is the tray setup. So sealants come in a light block black syringe dispenser. And this black dispenser tells me that I need a light to cure it. So as a dental assistant, the one thing that I know about dental materials, without ever even looking at the label, is when it's in a black tube, it's there because it's a light sensitive material. Next to this is the acid that helps the sealant to stick to the tooth. So we first rough the surface up with some acid, then we rinse it away, and then we place the sealant. So these are the steps. You select the teeth, which will be given to you. So dentist will say, we're going to seal tooth number 3 and tooth number 14 today. Those are both first molars on the maxillary arch. You check your air water syringe by blowing it to make sure that there's no water coming out of the end. Then we clean the enamel with the Profi cup and paste. Then we will isolate and dry the tooth so we can rinse it off, put a cotton roll up there or a rubber dam. Then we would apply the acid etch, which is the blue stuff here from this slide. Rinse the etch away, dry the enamel, apply the sealant, light cure it, and then check it. And there are some good pictures about this in your book, which I have reproduced here for you. So you can see this tooth is isolated, etched, and this is what an etched tooth looks like. It is frosty. See how it's like white there? And then the sealant is applied, and it's light cured. So the big thing to be aware of, acid etch is bad for skin, bad for eyes, bad for tissue. Keep it away from all of those. So the patient should have safety glasses on, and so should you. And we don't want it to get on the tissue. If you've had sealants before, you know what this tastes like. It is that bitter, awful taste. So if you've had that taste, what you want to do as a dental assistant is make sure you get your suction right down over the tooth so that the patient doesn't get a taste of that. Because what's the first thing they want to do? Close. And then we can't have them do that because that gets the tooth wet. And then we got to start all over again. So sealants only stick to dry teeth. Some people are allergic to sealant resins. And if they are, we should not be using sealant on them. So acrylate resins, there are some patients that are allergic to acrylics, and that is what we want to keep away from them. So let's see, that's about it for that. Questions? Okay. So we have said again, we want to make sure that we're motivating our patients and not scolding them. Okay. Let me close that. And this, and then that, and then this. Okay. And we get into our hand pieces and instruments. So I think it's tired. I mean, it's time. It's tired. This is tired. My computer's tired. It's time for the instrument of the day. And we'll just do this. Okay. And I'm going to get... So hard to, cracks me up. All right. So our instrument of the day, and we'll just take a look at the ones that we have here. It looks like we're really far away for some reason. So, hold on a second. And let's get closer. Maybe not. Okay. We're going to postpone the instrument of the day today.
I couldn't figure out how to zoom in on that.
Yeah, it's a little bit difficult. I had it working before I had everyone on it, but it looks like we're not there. I don't know how much you can see here, but I am just going to hold this up. So we'll do this one today. This is a shade guide, and a shade guide is used to take a color of the patient's tooth and then to, what's that?
You can't see it.
Oh, you guys can't see. All right, well that is a problem. Let's see.
I don't want to back up now, but I did think about it.
Can you see it now?
About half of it.
Okay, not so much. Yeah, this is, for some reason it does not want to let me zoom in. Let me see. It's moving.
Okay, we can see that now.
Okay. Awesome. All right. I don't know why it won't let me get closer. Tell you check everything, and then technology just says, ha ha. Anyways, so this is a shade guide, and you can see that it has all these different colors of teeth here. And so I can pull one out, and I could match it to my little guy here. And we can say, oh yeah, that matches. So what the shade guide is used for is choosing a color for the filling material. So when a patient has a filling in the front of their mouth, they want it to match. And often as dental assistants, we're very important in this process because a lot of the docs don't wear lipstick. And so they don't have the same sort of urgency about the color, right? So they often ask us what our opinion is, and that's a good thing. All right, so we will head back to our instruments. Let's see. There I am. Okay. Back to our regularly scheduled program. All right, I'm just going to take this off. Okay. So for instruments, being able to identify them, of course, is extremely important. And we've met our Mirror Explorer cotton plier on previous. Just a note there, all procedures begin with this basic setup. All right, so no matter what you're doing, look for the basic, you got to put it out. And then the rest of the hand instruments are typically arranged from left to right in order of use by the things that they do. So the first instruments on the tray should be the Mirror Explorer cotton plier, the instruments that are used to check the health. You can't see? Hold on. Is it back yet?
No.
No. Cool. Ugh.
Oh man, it's 7:17.
Better?
No.
How about now?
No.
Cool. Just break in when I hit the sweet spot. Break in. Oh boy. Let's see. Presentation.
They went home.
Okay. Do we have it now?
No.
Okay. Oh, I love technology. How does it work 1 minute and then not work? Maybe? No?
No.
We can't hear.
No, we can't hear you either.
Yeah, I muted because I didn't want you to hear me swearing at it, but. No, I'm kidding. I'm trying to be patient with it. Hang in there, hang in.
We can see most of it.
Okay. So, let's see. Hold on. Let me get rid of the. Is that better?
No.
No, but we can see most of it.
You
Is
can
it just really? Is it just really small, or is it like?
No, it's almost like it's blown up. We just can't see like the second half of the last word.
Yeah,
Oh.
it's really that.
Gotcha.
Not that bad.
Okay. If it gets worse, let me know. I don't know why it's doing that. I've tried every button I can find. All right. So after examination instruments, then we would have tooth preparation instruments. So typically what we have is we've got the health of the patient that we check, and then we're going to remove the decay. And so here are our exam instruments. Close-ups on them. And you have all of these pictures in your instrument book, which is a fabulous resource for getting used to these instruments. Better than me holding one at a camera 40 feet away. And then this is the most common enamel cutting instrument, which is the spoon excavator. Remember, we eat our mushy frosted flakes with a spoon. And so that is for getting rid of the decay. And then once the decay is removed from the tooth, we will restore it or bring it back to what it once was using amalgam or composite. The amalgam is the silver filling. The composite is the tooth-colored filling. And so we will place the filling material, condense it or squash it in, carve it, and then we'll use certain accessories to get this done. So if we're talking amalgam, we've got a carrier where we will fill the carrier up. Oops. Condense it with the condenser, smooth it with a burnisher, and then carve it using either a carver or a Clio discoid or a Hollenbeck. So these different types of instruments are used for amalgam. So if you're doing an amalgam with a dentist, they should be set up, the instruments on the tray, should be set up from left to right in order of use. And what that means is that even if you're unsure of what the instrument name is, you should be always getting ready with the next instrument on the tray. So if they're in order of use, you just want to pick up the next one and hand it. That's your safest bet, especially when you're new and you're unsure of what it is you need next. Our accessories are here. Accessories are used to help put an extra wall around the tooth, keep filling material from spilling over onto the gum, which is what the band and the wedges are for. Accessories are used to deliver dental materials to line the inside of the tooth, and then to check the bite when we are finished. Okay. And then we've got our composite instruments. And composite instruments are different than amalgam instruments. And their main difference is what they're made of. So stainless steel will tarnish composite. It will turn it silvery colored. And so composite instruments are either made of plastic, anodized aluminum, or Teflon. So this is anodized aluminum down here, and then Teflon is like your pans. And so these instruments are very fragile. So if you've ever used a metal spatula on your mother's Teflon pan, she probably killed you, because it takes the coating off and then the pan's no good anymore. So the Teflon composite instruments are the same. You want to be very careful with them and not scratch them. So here we have micro brushes and wells where dental materials can be placed. So the little brushes are used to place the materials on there. Our curing lights, which we've met before. And then for composite, we also have some finishing strips that go in between the teeth. They're like little emery boards for teeth instead of nails. And we also have palladents or sectional matrix systems that keep the composite from going down to the gums on the teeth. So here's the tray set up for amalgam. And here's the next to the composite. And so you can see that there are differences in the setups. And those are what you will run into when you get into a dental office. Now, the good news is, in the dental office, most of this is already packaged together. So we learned during sterilization that we liked our instruments in cassettes, or we like them all bagged together because we're going to use them together again. So really your job just becomes getting familiar with what order the dentist wants them in, and then what they're called so that you can pass them when asked. The next part of this is our rotary instruments, and what we're talking about here are handpieces and burrs. So we think drill and bit, but we never say that because that makes patients scared. So handpiece and burrs. Burrs are held in the handpiece by a chuck that opens and closes. A chuck is basically something inside the head of the handpiece that is going to be either open or closed to hold the burr in. And what they're used for is to prepare the tooth, remove cavities, shape the cavity wall, finish the restoration, polish different materials that we have, and polish teeth as well. And we start with the first handpiece, which is the low speed. We've met the low speed Profi handpiece, and now which we use for coronal polishing. But we have two more. We have one that is called the straight nose and one that is called the contra angle. And the straight nose has a very long burr and is used outside of the mouth, usually to trim dentures or other acrylics. So this is kind of like the one you will see in a nail salon when they're trimming your nails, because that's what they trim the acrylic with. And the other slow speed is the contra angle, and the contra angle is used in the mouth. So outside the mouth, in the mouth, and the contra angle is just a slower handpiece to remove. It's good for removing decay and also powering sharper files and instruments. So low speed handpiece goes together like this. It has a motor and an attachment clicks onto the top of it. That's the straight nose that we see. The high speed is all one piece. So this is how you can tell whether you've got a low speed or a high speed. The low speed has two pieces, and the high speed is just one piece. The high speed goes up to 450,000 revolutions per minute, or RPMs. That's really fast. And it uses burrs that are held in by friction, and they often have headlights. So here's a high speed with headlights. And chuck can be opened either by flipping open a switch, by pushing on a button, or by putting a key in. So I like to laugh and say this is the Chucky. Bad dental jokes are my specialty. So some other handpieces that you might see in offices, and I'm going to show you pictures because that's much more exciting, are the air abrasion handpiece, the Profi handpiece, as we've talked about, the hygiene handpiece with the contra angle and Profi cup. The surgical handpiece, which is an electric handpiece that is used for cutting bone during wisdom teeth removal and other surgeries, implant surgeries. And this has sterile water that is plumbed right to it, because as we learned a couple weeks ago, we can't get sterile water out of a dental unit because of that slimy biofilm that's inside the tubes. This is a laser handpiece that's good for hard and soft tissue. So you can use it on bone or teeth or cutting gums. This is an electric handpiece that's good for root canals. And then this one is an air polisher. And what this one does is it blasts out a combination of baking soda and minty flavor. This is one of my favorites to have done to my teeth. I love the feeling of the air polisher. So if you give me a choice between this guy here and this guy here, I want this one. All right, so that's the ultrasonic handpiece down there. All right. So one of our duties, or one of our largest duties around handpieces, is making sure that we know how to maintain them. And we talked about the fact that handpieces cannot be used in dry heat sterilization because it's too hot. And they should also never go in the ultrasonic. So they don't like to go swimming. So you never immerse them in liquid. And you will flush them on a unit for 20 to 30 seconds, which typically means just to run it. So it just flushes water through it, and you should always have a burr in it. Most handpieces will need lubrication, and most offices have a lubrication center in them. So all you have to do is put the handpiece into it, and it will lubricate itself. Dental burrs come in 3 types to fit in one of 3 different handpieces. So we've got the HP, which is the long for the straight nose cone on the slow speed. We've got latch type burrs, which go on the contra angle slow. And we've got friction grip burrs, which go on the high speed. Dental burrs have numbers that identify the head of the burr or the cutting end. And they also may be identified by shape. So the shape of the handpiece is attached to the shank by the neck, and the shank is the part that goes into the handpiece. So this is the working end, this is the attachment end. So you can see that these 3 burrs have different shank ends, but they have the same head. Does that make sense? So you will have burrs that have the same function, but we can change the speed of them or what they're used on by putting them in different handpieces. So this is one thing that makes burrs both wonderful and confusing, is that there are a ton of them, and they all have numbers. So when you get into an office, a dentist may ask you for a number 8 round burr. They may say, I need a 35. They may say, can you find me a 57? And you're going to think they're speaking another language, typically. I'll tell you my burr story. I had been assisting for a couple years when I was assisting a doctor who wanted a 245. And I didn't know what a 245 looked like. I knew it was a burr, but that's all I knew. And so I went to go find the 245, and I couldn't find it. 10 minutes later, I'm still looking for the 245. Patient's in the chair. Doc's ready to drill, but he can't do anything until I get him his burr. And he just sat there talking. He wasn't going to help me one bit. So finally the lead assistant came out of the room, and I was like, where's the 245? And she just opens a drawer, pulls it out, and gives it to me. She's like, see, it's labeled. So this is what I learned. Read. All right. So almost everything in the dental office is going to be labeled. And if you're paying attention, you can quickly discover which burrs are the doctor's favorite and where you can find them. All right. So that's what I didn't do. So here are these different burrs, and I'm telling you, they look beautiful on screen, but they are tiny in real life. So it is sometimes difficult to tell a round burr from a pear burr from a cone burr. All right. But these are the numbers that go with those shapes. And then we have Fisher burrs. And Fisher burrs can either be straight or tapered, and they can either be cross-cut or plain. So there's some different ones. And then we have diamond burrs, which are actually made of diamond, but not pretty diamonds. They're industrial diamonds, so they're gray looking. And diamonds are used for crown and bridge. And diamonds are told apart by shape. So diamonds can be flames or rounded or football shaped or wheels. There are different shapes to them. And then they also come in different grits. And typically, the darker the color, the coarser the burr. So if Doc wants a coarse burr, I'm looking for a dark, like a black or a green stripe. But if they want a fine burr, I'm going to look for a yellow one or a red one. And then we've got trimming and finishing burrs and lab burrs. And these are the 2. So lab burrs go in the straight nose, slow speed handpiece, and they're good for trimming acrylics. And the finishing burrs go in the mouth, and they're good for composites. Some abrasives that we use to polish our aesthetic materials or our materials that are pretty. like composites and porcelains are, they look like this, and they're almost always little sandpaper discs that are held on by a mandrel. So a mandrel is the attachment that's going to go into the handpiece, and then a disc can be placed on it. And discs can either snap on, like you see here, or they can screw on, like you see there. So here's some up close. There's a mandrel and sandpaper disc right up close. This is a snap-on. These are snap-ons as well. This is a new type. And then these are just some stones that are used, polishing points. So being able to identify these allows better patient care, but it takes time. So you've got some great pictures in your book, your instrument book, the little one, and that's what I would suggest doing probably as you get closer to being in an office. Because right now you have bigger fish to fry. You're trying to get the whole picture of what on earth do they do in that dental office. And then if you get somebody to hire you on, the week before you start, you are cramming your instruments and handpieces and burrs. Trust me, I know these things. All right. So, and you want to make sure that you're paying attention to detail there. Any questions on this one? Very quiet out there. Crickets. Okay. One more. Okay. So, okay, so this is the last chapter that we're going to cover tonight, and it is about the materials that we use for bringing back the form and function of the tooth. Our objectives. So to restore means to bring back the form and the function, the natural shape and function. And by far the two most common materials we use are amalgam and composite. Amalgam, as I've said, is the silver filling material. Composite is the white material. And then we've got some other things. We've got whitening products that we use in the dental office. And then we have a whole bunch of supplemental materials. And I like to think of supplemental materials like vitamins. So they're kind of like things that we use with amalgam and composite or with a crown to help the tooth heal or to stick it together. So we'll talk about those a little too. So what does it mean? Well, it obviously means to take diseased teeth and put them back together again. So this right here, this before and after, was done with composite material. And that's a pretty beautiful result, I would say. So if you are this patient, you are very happy when all is done here. And here's a before and after showing amalgam. So this patient has a little cavity there. And then here's the new amalgam down there. Sorry about that thing on the bottom. And then with this series, we've got some decay in these teeth here. And here the supplemental material is showing. So supplementals are things that we put down before we put down the
We can't
amalgam.
see the A, we can't see the before.
Ugh. Here, let me make it smaller. I don't know why this is doing this. Let's see, try this one. Is this any better?
No.
No. Is it better if I leave it? Is that better? Okay. All right. We'll leave it like this for now then. So you can see the before here now and the after. Makes a huge difference when you see that, right? And then the before and the after on those. But as I was saying, these supplemental materials are placed before we put the filling materials in. And they help to make the tooth healthier. So what do restorative materials have to be or have to do? What properties do they have? Number one, they've got to be approved by the American Dental Association. Number two, they have to stand up to the stress and strain that we put on our teeth. So biting into toffee and pulling on taffy, both two different things that are yummy, but that are going to put stress on our teeth. They need to hold up to hot coffee and cold ice cream. So they need to be able to stay with the thermal changes. They can sometimes cause a problem if there are two different metals in the mouth. So if you've got, and so some of you may have experienced this, I know I did as a child. If you've got a silver filling in your mouth and you get a piece of tin foil from a baked potato, and you chew on it, you're going to get a shock because basically saliva has salts in it that causes this to be a little battery. So two metals plus saliva equals electric shock. Isn't that nice? And we call that galvanism. They've got to be able to be stand up to corrosion, to not be soluble in the mouth. And then there are other things we talk about with flow and retention, which means how well do they stick, how well do they flow into the crevices of the tooth, and how do they set? How can we cure them in the mouth? Let's talk about amalgam. Amalgam is a powder and a liquid. It's supplied in a capsule, and the capsule is placed into the triturator, and it is shook back and forth. The triturator is a little shaker. That's a piece of equipment we learned a couple weeks ago, or last week maybe. And what comes out is a soft metal that hardens by itself over time. So while the metal is still soft, we are pressing it into the cavity. And amalgam is a concern because it contains mercury. It has been scientifically tested to not cause harm to us, and it's been in use for over 150 years. But there are some dentists and patients who prefer not to have the mercury in their mouth for many different reasons. And those patients will then want to move on to the tooth-colored filling material. Amalgam is very durable. It holds up very well. So here's the capsules, the triturator, the soft metal, and this is the amalgam carrier that we're going to load it into to bring it to the mouth, and we're going to condense it with a condenser, and this is our end result down here. When we are doing amalgam on a class 2, which we remind ourselves means in between the teeth on a back tooth, the class 2 has to have an extra wall to be placed correctly so that the amalgam material doesn't go down under the gum. And this just kind of details the steps to the procedure. And I would recommend watching the videos that come with our text for that. So let's talk about composites. That's the white filling that almost all patients are asking for these days because they're so much prettier. A white filling is made up of an organic resin, which basically is a fancy way of saying plastic. And it's also made of glass. So there's a plastic sort of fluid resin plus these glass particles. And the size of the glass particles and the colors of the glass particles are what give composite its strength and its color match to the tooth. So almost all composites are light cured. Some can be mixed together and will harden by themselves, which we call self-cured. But most of the time we're using light cured these days. We choose the shade and then we are going to apply it to the tooth. They're very moisture sensitive. Some dentists will like to talk to you about the evolution of composites. And what's important about this to know is that they weren't invented until 1950. And then they've gone through many changes as scientific knowledge has expanded, so has our materials. And so now there are really sophisticated materials out there that can be used to restore teeth with. But basically, you just want to know that they're not UV cured. So even though the light is blue and it looks like a tanning light, it's not an ultraviolet light. It's light cured, white lights mostly, or in the white spectrum. So there's the shade guide, which we saw earlier tonight, and some examples of composite. To assist a composite, we will transfer the etch gel and then the adhesive and then the composite. So basically, we've got to rough the tooth up. We've got to use a glue or adhesive to keep the tooth, to keep the composite stuck to the tooth, and then we'll place the composite. And here is a cartoon of that process there, and also the actual in place there. So to get a feel for that, those videos that are on your text are also a really useful thing. Composites then need to be finished and shaped with diamond and finishing burrs once they've been placed. That is different than amalgam. Amalgam is carved with a hand instrument. Composites must be carved with a burr and handpiece. So two different ways of completing the procedures. So here are some of the composite systems that are used to polish those up, because of course the patient wants to feel nice, smooth teeth when they are finished. Okay, so the last part of this has to do with liners and bases and cements. And these are the materials that we use to protect the nerve of the tooth or to stick something to a tooth. And so when we mix these materials, we need a clean spatula, a mixing surface, some 2x2s, some alcohol, and then we're going to mix together, usually powder and liquid if we have to mix it. So this one has actually 2 tubes of liquid that get mixed together, but you can see the mixing spatula, the material, and the mixing pad. And so my advice is when you see 2 tubes, put out equal lengths of each tube. All right. The rest of the liners and sealers and varnishes are all there to protect the inside of the tooth. And this is an example of some of the materials that we use. So basically, it's looking at the type of material and understanding how the dentist wants to have it transferred to them. And so these are placed under restorations to protect the nerves. Now, cements are used to stick things together. And when we say stick things, we're basically talking about crowns, bridges, inlays, onlays, and veneers. And these restorations are what puts teeth back together for many years. So this is what the cements typically look like. They're either in capsules, and capsules go in the triturator, or they are in powder and liquid, and they're mixed, or they are mixed together with 2 tubes, 2 liquids together. And so there's different materials that we go through here. Zinc oxide eugenol, or ZOE, is a very common one that's used to calm the tooth down. This is also called IRM. It's a temporary filling material, and it's made of oil of cloves. And oil of cloves is very soothing to the nerve. It's actually a natural anesthetic. So if you have a grandmother or a great-grandmother who may have told you to chew cloves for a toothache, this is why, because it actually does work. And there's the IRM or ZOE. Glass ionomer is a cement that releases fluoride. It's important in orthodontics and in crown and bridge, and it is really an excellent material. This is what most docs are using today, is the glass ionomer. And they come in capsules, they come in syringes that mix themselves that you just have to squish, and they do come in powder and liquid as well. This is glass ionomer for kids, and it comes in this rainbow of colors. And if you don't want a blue filling or a pink one or a green one, I don't know what's wrong with you. I'd have a whole mouthful if I could. So I think that's cool. It makes you want to be a kid. All right. Zinc phosphate is a very old cement, and you will probably never see it. I haven't seen it for probably 15, 20 years in a dental office. But it's kind of like, it's like a rite of passage. So if you have been to school for dental assisting, you should have heard of zinc phosphate before. Zinc phosphate is difficult to mix. It's mixed on a glass slab because it gives off heat as it is mixed. And so it has to be mixed on something cool so that the heat doesn't cause it to harden as you're mixing it. And so that is zinc phosphate, rarely used today. Polycarboxylate is one you may see, although it's not as common as it used to be. And this is a pink cement when it's all mixed up. And then whitening materials, which most patients have questions about, and you probably do too. So whitening materials are peroxide-based typically, and they're made from different concentrations. And what they do is they allow oxygen to enter the tooth, which kicks out the colored substances. And because oxygen is colorless, it brightens them up. And so they do not harm teeth that we know of long term, but they can cause sensitivity to hot and cold, and they can cause gingival sensitivity. So different things. There are two ways to do it. We can either do it in the office with a laser, which accelerates it, or we can give the patient the gel to take home, and they can use every night for about 2 weeks. The at-home requires commitment. The in-office requires money. And so some before and afters there. So what material you use is always going to be based on what the doctor likes. And my advice is to always read the manufacturer instructions. And there isn't a little at-home project here that I suggest at the end of this. Get yourself some baking soda and some Karo syrup or some cheap maple syrup, some imitation, and get a tile or a cutting board or even a coated paper plate and mix the baking soda and the Karo syrup together to practice mixing dental cements. You can use like a drywall tool from Home Depot or get a little cake decorating spatula. And it's kind of a fun way to get some experience with this. And there's also, they sell dental spatulas on Amazon too if you're really into it. So some different things. So I say mix a thin one, mix a thick one, get some experience with that. All right. And with that, we are at the 8 o'clock hour, everybody's favorite hour, right? So we're done. So don't forget that we are skipping over chapters 15 and 16 for now. We will come back to them in 2 weeks. So chapters 15 and 16 are your radiation health and safety. And that's when things really get serious around here. So enjoy your Thanksgiving. Have a great week. And I will see you next Monday. And we'll be doing chapters 21 through 23. Okay, so catch up if you can. I know it's a lot now. This is when it kind of piles up. There's a lot of chapters. All right, so have a great one, everybody. See you later.